So at this meeting, there were quite a few abstracts addressing clinical trials in which an attempt was made to change the natural history of smoldering myeloma. And one of them that caught my attention was the use of elotuzumab in combination with lenalidomide and dexamethasone. You want to comment on that, Adriana?
Well, I think it's very nice, both the ELO study, ELO-RD, and the IXA-RD, which were the two
Ixazomib,
that,
yeah.
Ixazomib, thank you. They give us an opportunity. I think, you know, we're moving earlier and treating patients before they have end organ damage is much more palatable now that therapies are so well tolerated. And what I really liked about both of these studies is that they're adding on correlative studies and other ways for us to inform and learn about the disease process and what is it, can we distinguish which patients do benefit, which ones could maybe get away without therapy, and that maybe it's not such a clear cutoff that it's a plasmacytosis, an exact number. You know, I think we have good data and guidelines to support certain clear definitions, but in clinical practice, I think we all sort of have a sense of this patient is about to get themselves into trouble, and maybe someone with 50% rather than 60% in the marrow would be appropriate. But I think I really look forward to all of this other data, like the exome sequencing and RNA data that could maybe help us understand the patients better.
So my take on these trials were that they all, of course, show a fairly high response rate. They all seem to trend towards decreasing the time to which you get myeloma. Were there any, Tom, in particular that stood out for you that were interesting?
Yeah, so what I would say about those two trials are both actually, in my mind, had relatively low rates of complete response. And I think if we're going to treat smoldering myeloma, and we're not going to call it smoldering anymore, we're going to call it myeloma, let's treat it with our best regimens. You know, and we'll talk more later about what our best regimens are for newly diagnosed myeloma, but I think I would be more aggressive in this patient population. And I think, you know, we have a lot of data with RVD and a lot of data now with KRD, and now we're getting data with quadruplets. And so I think my take on this is that if I'm going to treat them, I'm going to treat them with a more potent induction regimen.
So you feel they're being undertreated with these regimens then?
I'm not sure if it's undertreated, but I think we can treat them better and try to induce a higher rate of complete response. And at the end of the day, we're going to be looking at minimal residual disease, MRD negativity. I don't think we're going to get the same MRD negativity from these two regimens, ELO, lenalidomide, and dexamethasone, or Ixazomib, lenalidomide, and dexamethasone.
So I listened to the presentation yesterday, particularly about elotuzumab, lenalidomide, and dexamethasone, Faith, and one thing that struck me was that there were 2 deaths out of the 50 patients, which both looked to me like they were likely therapy-related, diabetic ketoacidosis and myocardial infarction. I guess that's the concern, right, that you're over-treating and people who have a decade-long expectation of survival are being put at risk. What do you think about that?
Yeah, I mean, I think, and that's why we have to really tighten up on those criteria, because I think that we know these drugs are safe and effective, but we really have to make sure that we're treating those patients that are myeloma and that are not going to be those stable cases. So there's definitely some fine-tuning there, and I think my own feeling is that we're never going to get very strict guidance, and to some extent it is going to be a little bit more of a gut feeling. I think, as you said earlier, you know, maybe 50 and 60% and saying this is 50%, this is 60%, I shouldn't treat. I'm not sure that's the way it's going to be. I think it's going to be a little bit more as the movie thing, see the patient, make sure and monitor them really closely so that we can pick out the best one.
And Adriana, you mentioned the correlative studies. I mean, one thing that would concern me would be that you would sort of potentially be breeding clonal evolution and drug resistance, which I guess we'll learn from those studies.
We will, and again, looking not only at the plasma cells, I think the more we learn about myeloma, it's not really about the tumor cells themselves, but the effect they have on the neighborhood, and what is the behavior of these other members of the microenvironment. Because maybe, you know, just to play devil's advocate, I wouldn't treat a smoldering myeloma with my best, most aggressive anti-myeloma therapy, but maybe these are patients that I can modulate the microenvironment and have a completely different philosophy in the therapy and prevent them from ever having the end organ damage.
Let sleeping dogs lie mentality. Raphael, Tom mentioned that if you're going to treat these people, maybe we should be aggressive, and Dr. Mateus presented at this meeting an update on her very aggressive treatment approach to high-risk smoldering myeloma. Do you want to comment on that for the audience?
Sure. So Mary V. Mateos presented the GEM-CESAR trial, which is an approach that states we will give you the best treatment there is available, because this treatment would be the best treatment that's available for active myeloma. So for the audience, it's KRD followed by stem cell
What's
transplant.
KRD? You better just
So
define it.
carfilzomib, lenalidomide, and dexamethasone, followed by autologous stem cell transplant, followed by more of the same of the endogenous consolidation, then to be followed by lenalidomide, dexamethasone maintenance. Not surprisingly, they achieve a very high rate of response, and the patients obviously get deep control of their disease. But the key question remains, which are those patients that need to be treated? I think as these trials have evolved over the years, maybe some of those patients nowadays we would consider in need of treatment, and maybe some of those patients we would say they're not quite there yet for treatment. Now, Dr. Mateos has paved the way in telling us, you probably should consider treatment of early myeloma or smoldering myeloma with her original publication with lenalidomide. Again, this patient's, stringent CR rates, and, over 30% of patients, they get to a high rate of, MRD negativity. So I think the question is not whether we have the tools. The real question is when do we use them? And that goes back to the origin of our conversation. We can't go back to the 1970s when you have 3 lines of criteria. So we have the criteria, we have the genetics, we have the dynamic changes over time, and then we need particularly 2 biomarkers, free light chain for renal damage, and we need a good biomarker for bone disease, which we unfortunately don't have.
Yeah, I think I saw a patient of yours a couple of weekends ago who we were following. You were about to start treatment, then very quickly developed some renal failure. So you have to, certainly I get worried when the free light chains are getting high and if there's any movement in the creatinine. So I kind of get the sense from the panel that people are still a little bit reluctant to treat smoldering myeloma, that watchful waiting for the community is probably still the safest bet if you're not entering your patient in a clinical trial. Would people agree with that, or is that?
Yeah, I think so. I think the key, as you said, is watchful waiting. And I was going to say, years ago, watchful waiting could be 3 months or 6 months. And I think I would like to argue that at least for the first 3 months, you're actually maybe more aggressive in your watchful waiting and really make sure that, because that 3-month period is important. So maybe monthly or something to begin with.
As every so often you'll find a patient you think needs treatment and 10 years later you're still watching. So I think those are important. We define those patients.